Sarcoma.
Have the follow-up with you, then you are very certain that you are with the first time I was presenting in 2012, it's very easy like this. But in 2011, if presenting like this, maybe somebody says that we can see the matrix. So if you see that there is an area of lysis where you can see black spot, and subsequently it is developing into a bright zone. So that is something which is the reactive remodeling of the bone that is actually happening. And then we have followed this in this thing. And in the last 2022, it was not only visible. So there are no touch lesions which can come into the bone and go without even causing much of the trouble. So that we have to identify, and there are so many into the bone, and that's why there is a lot of problem, because the ratio of benign versus malignant is 200 raised to 1. So that is something out of 200 benign bone tumors, you might have 1 or 2 malignant, and that might create a confusion that people are denied of biopsies and other things, and things like that. They will curate and then it will come. So it could be lipoma, like having a ground glass matrix with remodeling, fibrodysplasia, and then cortical, very sharply marginated, non-occupying fibroma, and osteofibrous dysplasia. You can see that this has been biopsied multiple times. During biopsy, there's a path fracture, but it is healed automatically without doing anything. So these are certain lesions which are no touch, and like osteochondroma is the commonest one, and chondromas. They are actually still causing a lot of trouble if people don't diagnose them easily, do biopsies, and again the answer is a query between anchondroma and chondrosarcoma. Then coming to when the patient is having both pain, swelling, and massage. So you might come across in your practice. So this is 4-year-old boy, again having pain and swelling. What we see here, the patient was having a lot of pain, but it has been reported on X-ray as non-occupying fibroma. They went home and the swelling got bigger. At the time, they did an ultrasound. Ultrasound showed some mass. They did FNC from that, and it has been reported as osteogenic sarcoma. After osteogenic sarcoma, for the staging purpose, they have done an MRI, and finally they decided that they will take the treatment into TMH. And when they presented into TMH, we thought that there is something which is very unusual. The history might not be very clear. And what we have seen that there is a faint ossification. We asked that what is the other history. The patient was saying that it was not relieving, so they have done some massage. During the massage, what happened, there was some tear and it has formed into a myositis ossificans. If you biopsy immature myositis ossificans, they always result into osteogenic sarcoma. Okay, and this is how it has matured. It has been observed doing well. So there are many overlapping things that can come across such a benign entity which is mimicking like OGS on histopathology. And at the time, we need to take account into the radiology opinion whether actually we are dealing with something benign or something which is very aggressive. If it is going to be an osteogenic sarcoma with such kind of contamination, it warrants an amputation. So these are the things which we have to collaborate with each other every day. So I, anytime when you going to the practice and you see that there is a soft tissue which is having a lot of edema outside the muscles, always suspect myocytic ossificans first. It's easy to diagnose on CT scan because you can see the peripheral rim of calcification. There is a donation that is there, and there is edema. So it is easy to diagnose. But on MR, you can see the ossification, but it is very difficult for the people, those who have not seen it, how the myositis looks like. So they will confuse on ultrasound and this thing, but it's relatively an easy diagnosis when it comes to an X-ray and CT scan. So if there is a doubt, you will deal with the next level of investigation in the form of radiography. Either you can do a CT or you can do an X-ray and you can confirm your doubt. Again, the pain type and sequencing, that is also something which is more important. He's our own resident. Few years back, he is having pain in the foot. He wanted to reduce the weight, so he was climbing up and down to 8th floor every day. And what happens actually, he was having a lot of pain on walking. So the first X-ray that has been done was absolutely normal. Again, the pain aggravated significantly, and at the time we did an MR, and we find out that there is a cortical break and there is a lot of marrow edema and soft tissue. What brightness you are actually seeing it is actually an edematous tissue. So at the time when we repeated the X-ray in the November, there is a development of the periosteal reaction, and you can see the lucency that is because of the fracture. So basically, it is a stress fracture because he was going exerting too much on the foot, and that's why it has resulted in it. So certain things that they are unexplained marodema. Marodema means when you have edematous sequences, this is the stir sequence, and in the marrow pad will be black, and whatever it pointed out to be is going to be edema. So if you have a lot of edema around the small regions, then you have to suspect these three entities that will routinely come across. You might have stress fracture, osteoblastoma, and infection. And if you do biopsies, sometimes these biopsies are inconclusive because most of these are actually radiological diagnosis. So cortical infection, and because if it is not targeted well, you will not get the biopsy because the nidus is going to be only 2 to 3 millimeters in thickness. So MR is very good tool when you want to see the edema because edema is a marker of aggressiveness. It will tell that probably you are dealing with something much more aggressive. Either it could be an infection which is of higher grade, or it could be a tumor which is of higher grade. So whenever you are seeing edema into the MR sequences, you have to identify that whether we are not dealing with something which is very aggressive. Similarly, these might show uptake. The edema can appear so bright, even though the nidus is like this only. Whatever you are actually seeing outside is only just an edema. Again, when you are doing an MR, you can actually think that from where actually to biopsy. In this particular case, it is diagnostic, and where you see that the nidus is having the same intensity of the artery because it is a more of a vascular tumor, and you can see that it is having similar intensity changes, and it is a classical diagnosis of osteoblastoma. You don't need to biopsy in these type of tumors, but certain areas where actually when we are doing under the arm, it is done by orthopedician. Sometimes we will get that we are not getting the biopsies because what is happening, the entire center is having necrosis. What is it is the viable, and at that time the imaging will help to take a representative sample and actually then it process it, and it turned out to be an actually heaving sarcoma with a lot of necrosis inside. So dynamic contrast actually helps. What are the viable areas in that particular thing? Again, you are seeing that most of the presentation of these tumors are specific to certain category of age when you are coming up. So this is 40-year-old. I don't know how many of you have seen it. If somebody can actually pinpoint that what could be the etiology in this particular patient. 40-year-old knee joint pain. There is a lot of tenderness, and then we are seeing that there are multiple osteolytic lesions involving the distal end of the femur, patella, tibia, and other things. What is your diagnosis? So tumors usually arise from a single bone. It's something which is much more, it is either going to be systemic condition. It could be anything. It could be infection, it could be myeloma, it could be TB, it could be whatever it is. So if you are seeing that, but in general, what we follow into the ESC is that something which is more than 40 years, we have to suspect certain things, especially the metastasis, because these are very common. Even though the patient has presented only with the knee joint, and actually we have advised that because we are suspecting it could be match, it could be this thing. And if you are seeing cortical match, it's more likely to be bronchogenic CA. But we wanted to rule out whether there is should not be infection because these are too many opacities. And when we did, we feel that there are miliary nodules. When we did the MIP scan, this is in which you can separate the vessels from the nodules, and this is very good in separating them. There is a large left hilar mass, and actually when we biopsy it, evil part it is actually in metastatic adenocarcinoma of primary pulmonary erosion, TTFL, that was positive in this particular patient. And this is how the diagnosis is done. So something, when we are talking about age, there are a lot of things that can come across. So all the lesions are in the proximity here. Okay. What is the differentiating feature with age? So this is 17-year-old having multiple involvement of the bones. It is involving actually, you can see that femur is involved, tibia is involved, fibula is involved. Again, again, if it is unfused skeleton, we are dealing with an aneurysmal bone cyst. Here you can see this metaphyseal base, eccentric, the particular giant cell tumor, having ring and arc-like matrix involving this thing more than 30 years chondrosarcoma, and more than 40 you will think of metastasis. So everything same, location is the same, but it makes a difference if the age is different, the diagnoses are going to be different. Again, even if it is the same bone, but it is having different locations. So like this is epiphysis, it is chondroblastoma, this is metaphysis, eccentric, chondromixed fibroma, it is postofibral dysplasia, and cortex lower, it is going to be known as like fibroma. So locations actually make a lot of things, a lot of sense, and that's why the X-rays are extremely important, especially when you are actually evaluating these bone lesions, more than what the information is obtained from a PET CT or sometimes MR as well. So when we see that there are X-rays are going to be normal, we have to do the next level. Okay, either they are non-diagnostic or whatever. In this particular patient, 23-year-old having pain and tenderness in the right hip, what we see here that we don't know where exactly is the abnormality. It has been not written what is the on examination findings and everything. And we have advised an MR. And what we see on MR, 10 centimeter size of the region arising from the right iliac bone. It was absolutely normal looking radiograph. Absolutely normal. So in flat bones, you don't rely too much on the radiography. In extremities, it is okay to do, but if you are coming across some patient which is having persistent symptoms, always ask for MR, and that is going to be the next line of investigation. Just after the post, you can see the size of linkage that is having in this particular patient. Then and actually is affected. So it was actually round cell tumor that was there because it is a very large soft tissue component. So if you are having exponentially large soft tissue component, you have to suspect it is going to be round cell tumor. You don't know whether it is having something else or lymphoma, but given that it's more likely to be in that spectrum. So there is always learning point that in symptomatic patients, when the radiograph is not giving information, or maybe it is very not diagnostic, we have to do next level investigation. In this, the patient was having a lot of pain. X-rays were absolutely normal. He asked in this thing, it was an infection that was sitting here, and you can see on the still the kind of edema, the soft tissue edema that is actually having. So great amount of information can be missed on radiograph. So we need to know that, and something which we can actually diagnose on MR and differentiate between the tumor as well as the infection most of the time. So that we do. Then again, coming to evaluate, suppose there is some lesion. In this particular case, these are partial base. We need to know certain terminologies. This is the partial plate. This is the epiphysis. The broadening that happens is the metaphysis, and the cylinder part that is going to be the diaphysis. So if we have tumors which are located in the pipes, which are very sharply marginated, lot of surrounding edema. What we see here, this black area and this bright areas are actually edema. And these are typical signs of a chondroblastoma that we are actually coming across. So benign lesions sometimes can throw edema, and we need to know that certain type of tumors, like it could be osteoblastoma, chondroblastoma, TMS, osteoblastoma, these tumors can have these kind of issues. So this is osteoblastoma. It has been sequence to the curative. This is how that is going to be followed. Osteoblastomas, osteoblastomas and chondroblastomas nowadays are treated by interventional radiology. You can just ablate these areas and actually post-ablation, you see that there is nothing. So it is extremely safe procedure. You don't require any opening of the spine, any laminectomy, any other issues. And the patient can be discharged on the same day, and it is free of the symptoms. Again, you can see that this is an chondroblastoma, and you can ablate it, and post-ablation, the activity will go down to zero. So the most important part that comes is the benign versus malignant. How will we differentiate benign versus malignant? This is a novel sign actually we have put into IC to identify that how to identify radiologically as a giant cell tumor. If you have T2 dark areas like this, and you have intermedial bright foci in this terminology has been taken from the dermoid cyst, in which it will have a similar appearance, and that's why it's called as a chocolate cyst of the bone. And it will help in identifying that probably we are dealing with a giant cell. So we need to remember the pattern of bone destruction, and this is something which is extremely crucial when we are actually trying to differentiate the tumor, whether it is benign or malignant, based on the biological activity of the bone. And it is having its own behavioral significance, the kind of response that it is getting from the host bone and other issues. This has been characterized way back in 1960 with very great detail, but it has not been adopted that much because it is having 15 variables, and then his student he actually made it to 3 variables, and then it is easily followed up. So this is how he has actually at that time in 1960s, he tried to assimilate that if you derive into the categories. So the first category is going to be the geographically well-defined area. So it's something which is having very geographically marginated area. This is going towards a chondroblastoma. Something which is having more aggressive, like giving sarcoma. So if you see the 5-year survival and the average delay in the diagnosis, most of the malignant tumors will present early. Most of the benign tumors will have delayed presentation. And the survival, actually, the more the worse pattern, the worse will the survival. Even Ewing that is presenting with a very sharply marginated tumor will have a better survival as compared to this tumor that is presenting in this category. So that will indicate even that all Ewings will not follow the same pattern of biological activity, and that is actually you can determine on the X-ray. So this is something in which I am again repeating that these are simple bone cysts. So location will help. So this is metaphysis, this is cortex, this is eccentric, that is giant cell tumor, and this is metaphysis, that is sensile, that is going to be ABC. So all these we call the geographical margin because we can actually draw from the pencil that this is the delineation of these margins, and that's why these lesions which are actually having a potential to locally recur can be curated. Otherwise, you require resection in most of them if you don't know what is going to be the margin of the tumor. Permeation, so that is most important. If you see permeation, then you don't know where exactly the tumor is ending. So we cannot, like earlier, we know that it is very sharply marginated. Here we don't know where exactly the tumor is going. There is a soft tissue that is coming up. There is a soft tissue that is coming, and we don't know where exactly is the margin. And this is something the Codman's triangle that you can actually see, and it's very, very classical for malignancy to see on your X-rays. So there are many things that has to be seen when actually thinking about the margin, and there is a lot of combination of the patterns, whether it's parodic, regular, lobulated, multicentric, poorly defined. But something in you don't see the lesions that is called as invisible margin, and you see those lesions on MRI. So the concept of margin is actually about violence factor. In this particular patient, we have to see that it was suspected that it could be a low-grade chondrosarcoma. But when we biopsy it turned out and chondroma, The biopsies, again, after doing the PET, again turned out to be chondroma. But we are not very sure how the patient will behave, and we asked him to do the resection, but because of the major resection issues and his occupational challenges, he opted for an active surveillance, and we are doing the active surveillance. He is doing well. So something which is changing or stable margins actually will indicate that how the region will behave. If it is these margins are stable, we can do active surveillance. I'm not going to the details because he also suggested that in the 1980s or 60s that AI will do this thing and that thing, but it's certainly not doing anything. So there are descriptive and decision and probability metrics, and that is something which we have to remember. It is like how better we are actually to differentiate regions which don't require any intervention from the regions which require intervention, and which is more accurate, humans versus computer, or who is more accurate in grading and giving diagnosis, whether giving a wrong diagnosis affects the grading or uh, difficulty in assessing the grading will affect the diagnosis. So all those things are actually there. But if there are certain rules actually people are actually following, then actually they can give a good diagnosis in those areas as well. So this is something which is stereophylation. Again, the indicator to differentiate between a benign and malignant. Something like this is going to be extremely solid. It is going to be benign. Something which is having an incomplete break in the stereophylation is going to be malignant. It's a different matter what kind of histology it will. Like in this particular case, if you have a very cloud-like fluffy matrix and sunburst kind of appearance, it's almost 100% virtually diagnostic that you are dealing with an oxygen sample, whatever the biopsy will say. So these lesions can be upfront taken for resection if it is not metastatic. Again, there are some certain Portmans that it can be presented for and this thing. So these are the things that we are dealing with. Again, what we are talking about whether all aggressive lesions are going to be malignant. It's not likely. Like we are seeing this kind of destruction that is there. And we see that almost entire head of the that is gone, it is going to the scapula and all this sort of stuff that is there. There is a necrosis that is, and it was actually. So we need to do biopsies in all of these aggressive regions because you don't know what is turned out to be. So it has been suspected as tuberculosis, but yes, in this occasion, the biopsy will confirm actually it is a granulomatous etiology, and that's why the treatment are going to be entirely different. And if there is a doubt, we need to follow that in India. Deep. Again, this is something it has been labeled outside as an osteogenic sarcoma, and then the patient came, and then we are not suspecting, we are suspecting that there is something wrong, and actually it was pseudoaneurysm. It was so big because the patient was having a football player. There is a very sharp osteochondroma. Sudden hit was there, the vessel ruptured, and there is instant development of the 20 centimeter swelling. And you need to know the history as well, actually, what you are dealing with. This patient has been biopsied. It has been reported in the clinic, that the PET has been done. But actually, it is good that he has been referred to our center, and that's why before doing surgery, we always review these images. And you need to review these images because before you put needles, actually you can puncture these vessels and then it can blast it. And so if you're doing a big surgery, maybe it is requiring resection and other things, you need to review. You need to review both the radiology, you need to review both the histology before contemplating any kind of major resection. Again, coming to know that can we predict the kind of metrics that the tumor is having? It means that can we tell that it is going to be OGS, it is going to be chondro, it is fibrosarcoma, it is going to be something else. Yes, you can predict. Cartilage, it is almost virtually 100%. If you do NMR, it is very unlikely that you will miss the cartilage. The cartilage having a specific pattern, it is going to be T2 right. The kind of peripheral lobular enhancement that we see typically in melangiomas of liver and other things, it is virtually diagnostic that you are dealing with a cartilage tumor. The second issue will arise whether it is benign or malignant, that we have seen that how to differentiate the biological activity of these lesions, whether there is any edema, whether there is any periosteal reaction, what is the kind of margin it will have, and then all will tell, yes, it is a cartilage, malignant, or the sarcoma. So earlier it was being predominantly on X-ray, but now MR is contributing a lot of into this thing. So if you have very dense cloud-like matrix, it is going to be osteoid. If it is having malignancy, associated periosteation, other soft tissues, osteogenic sarcoma. Similarly, ring ankylosis soft tissue, chondrosarcoma. This is fibrodysplasia, ground glass opaque matrix that is there. So you can differentiate all these matrices, and this will help significantly to the pathologist when there is a doubt regarding these matrices. How MR will help? This has been reported as FT, biopsy, 3% added to the histopath. You can see the floating membrane that are there, and that's why something which is looking on X-ray might have something. So all these are actually googling. This has been reported as very extensive genital tumor actually was present by fibromas in those days. So it is very good in differentiating cyst versus fibrous lesion. So if there is a doubt whether it is a cyst or fibrous tissue, you can do an MR, then you can actually differentiate between. I'm not going into this. Again, I will just discuss this here. This is a 10-year-old boy. Actually, they are CGI and they're having very anxious about this thing because it has been reported that there is a lot of marrow infiltration. There is a surrounding soft tissue infiltration. He was having pain since a month. And actually, when he came here, he told that nothing to be done because it looks like express paralysis. And they are not accepting that diagnosis because it has been FNA and FNA showing it is looking like a round cell tumor, suspected ring sarcoma. And you see that there is a lot of marrow-edema that is happening. We tried to talk to the children, but actually they told that we know that he is our child and he is not hiding anything from us. But when we spoke to the children, actually they have put into the summer camp and he was doing 4 hours of football playing, another thing, and after football playing, actually there is a lot of pain, and that's why this stress fracture occurred. Because there is an abnormal stress during that short period of time. He was not playing regularly, and because he's having his holidays, school holidays, and then he was put to play 4 hours there, and actually how it actually resulted. And then we demonstrated that the polypher is leaking. Last 10 years, he is doing very well. So it is extremely crucial that sometimes we will have very aggressive diagnosis on histologies, but we need to confirm whether it is matching with the radiology. That is something which is very, very crucial. So there is, don't do any interpretation of MRI without radiographs, and then there are fluid field levels. Fluid field level don't give diagnosis because there is connectivity many conditions, and then X-ray will help whether you are experiencing some or other kind of this thing. There is something to need about. There are different management aspects. Unusual bone cysts nowadays are actually dealt with either the form of sclerotherapy most of the time, and if it is not responding to sclerotherapy, we do embolization. And then we may think of doing a resection. So these are the two first steps that have been done. So ABCs are usually most of the time 95% of the time it is managed by therapy nowadays. And this is something which is like ABCs, like of pattern actually can be seen tentative OGS, and that's why all ABCs have to be proven whether they are actually just pure ABCs or they are secondary changes with the on the blastoma or OGS. So the treatment is entirely different. Here it is embolization, and here it is resection. Coming to the staging of the bone tumor, what we actually do. So we will clean the bone, proximal joint, the distal joint. If the femur is involved, we will clean hip joint and the knee joint. If the tibia is involved, we will clean the entire bone, putting the knee joint and the ankle joint. And then we do a dedicated imaging of that area to know exactly what are the things we are doing. So we have to see the extent. Extent means what is the length of the tumor, whether it is actually going to the biceps, because it will affect the surgical planning, what kind of plant they have to choose and other things. Whether there is a joint involvement, if it is involving joint, probably they might have to be. The kind of neurovascular bundle involvement, the neurovascular bundle involvement, that is outside, and whether it is involving the neurovascular bundle, again, they might have to decide for the amputation. Second thing is about history. You know, see that there could be not moving ahead with the surgery because they are showing that if there's under to metastasis, our entire exercise will go waste. So that's why we biopsy this particular region and it turned out to be non-control. So a lot of synthesis will go what exactly the extent of these regions and that were one-to-one discussion before actually going ahead with the big surgery. So again, coming with the narrow-based lesion, I know most of the trend that is in CMS and outside is that uh, this thing, the PET is better in narrow disorders, especially the multiple myeloma. But what the recent evidence is saying in a randomized data set is that the detection rate of whole body MRI but PET scan and it's into nice guidelines as well. And most of the guidelines you will see whole body MRI is overtaking over PET scan. And this was a randomized study done in the NHS. That means recently published. It shows in that study it is like 81 versus 15. So the sensitivity of picking narrow lesions by MRI is 81%. PET scan is very, very, very poor. You are missing a lot of information if you are doing PET CT. So there are another few sequences that can be helping differentiating various lesions from inflammation versus edema and other things that are being taken off. I'm not going into detail, but will help in differentiating what kind of lesion actually you are looking at. And about many other things in which we can suggest that it might be melanoma because it is different. It might be having ossification because of calcification. It might be neurogenic nephrotic areas, other things, and these are susceptibility sequences which are actually coming in a big way in simulation of this. Again, it is very simply safe to do NMR if the patient has a big blood. The only contraindication is the battery operated devices, that is the cochlear implant and the pacemaker. Nowadays, those are also coming with the MR compatible mode. So you need to check with each implant, but apart from battery operated devices, you don't need to check. You can straight away go into the MR scanner, do an MR, and whatever amount of information required, they can give. This is the collection. So in both CT and MR, there is no contradiction that you have to tweak certain protocols to get a good quality because it can compromise the quality. That is the only issue. So then again, the metabolic imaging, there is some role when we suspect maybe it is a cartilage, big tumors, we don't know what is going to be the focus. Sometimes we ask for a PET, but it is not proven yet whether it's any help in guiding the treatment. Again, for the response assessment, if there is no uptake and there is a almost shrinkage of everything, full response, that is a good response. Something that is where the activity is persistent, the cognitive is persistent, the marrow is persistent, it is actually a poor responder in that case. Again, one need to do that image-guided biopsies before doing and one need to identify whether if the patient is presenting to you with some certain kind of fracture, whether there is not going to be any pathological fractures. So these are the two things in this. The kneeling has been done, suspecting this fracture. What they have kneeled into the tooth. They have done into the TR, and when you do the imaging post-operative, when the patient has actually having swelling that is developed at that side, you see that the entire nail is to the tumor, and it will contaminate the entire area. It will require the hindquarter amputation, the entire leg will go. So these are the things that we need to remember that not all fractures that are coming to us are going to be routine fractures, yet specific pathology, and it has to be biopsied first before actually treating these patients with any kind of infection, plating or nailing or whatever it is. So just to summarize these things, then we will talk about certain responses and other people. So we need to know the age that will help putting out certain differentials in that particular age group. We need to look at the radiograph. So components are actually margins, shape, the restoration, temperature, the line and medicine. Soft tissue component and already marking the kinds of aggressiveness. X-ray could be either diagnostic, if you don't do anything further, you stop there. So these are going to be not experienced, or if they are non-diagnostic or maybe normal, we need to evaluate with MRI and find out whether there is anything else. And if there is an, you don't see any lesion, but you see edema, then these are the three things you have to rule out. The X-rays are going to be diagnostic. If it's benign, again, you have to identify that whether these are touching out, or if they are benign aggressive, whether we have to evaluate with MRI or not, that we have to decide it. Then aggressive lesions, we have to rule out the infection mimic, and then we have to give the guidance, the kind of X-ray technique we are evaluating, whether it's osteoid, chondroid, fibroid, down, cystic chondroid, and others, and whether we are actually using with some kind of mix that we routinely come across systemized surgical. We don't want to do amputation of patients or do limb salvage surgery just for a benign code is justified and observation. So there are, these are what we have discussed is they are specifically valid and useful concepts because they are done on the patient that they evaluated the kind of impact they are actually having the clinical practice with the 5-year survival data. If you try to differentiate these things based on the variation reaction and making control of the margins and other issues, and these are very natural. So you have to remember only 3 or 4 descriptors. What is the relation? What is the margin of the tumor, whether it is of which component or not, and other things. So even though sometimes when we don't know what is the diagnosis probably that we are dealing with, both in the histology as well as the radiology, we can tell that it's not going to behave like a benign lesion. It is more aggressive, and that actually helps in actually tailoring the treatment or the prognosis that we are doing with the patient. So I think if there is any question we would like to take, and meanwhile, I think we can switch to the next speaker. Might be benign, but you don't know what is the, when you are the primary side you are dealing with this that is going to the output of the but it is going to the fabric. So when we are giving contrast, it will help to identify the certain focus, niditis, and other issues, and it will tailor whether you are dealing with a benign, because the uptake and the graphs that actually are going in the dynamic phases. If it is having rapid uptake and rapid fall, it will indicate that there is going to be new antigens. And if there is a new antigen, it will indicate that we are dealing with a malignancy. If there is a graph which is showing rising pattern and then plateauing or maybe progressive healing, it will indicate that it's going to be probably benign. That can happen into fibrous lesions like you have fibromatosis, you can have into neurogenic tumors like schwannoma and other issues. So it will help to categorize in the diagnosis. Also, it will help in identifying necrosis, non-necrotic areas, because the necrosis will not enhance. Even though it might have variable signal depending upon the how dense is the necrosis, the signals can be variable. It might be dark, it might be bright, it might be distinct, but it will certainly not enhance because it is a dead tissue. So the tissue which is taking uptake is going to be live tissue. So that's why it is helpful. So when we begin, we don't know. It may be benign, it may be malignant, and we will not ask the patient to again come back just for the contrast. If you're doing it, we will do it at one go, and see, as compared to this thing, MR contrast is far safer, and the amount of dose that we give is hardly 8 ml to 10 ml, unlike the coordinated contrast, which is having around 70 to 100 ml. So if they are safer, the amount is not that big, and it can be given with any simple butterfly cannula, not requiring the existing until unless you are actually planning to do a dynamic assessment of the care. So, go to something. I think this is the data. Data coming to I think that the kind of chemotherapy will plan and do everything since last 2016 to last 2021. But I'm coming to the post chemo imaging that actually we are doing it. So there are certain aspects. Uh, that one is the anatomical aspect, where we will see that the shrinkage of the tumor morphologically, the edema is going down. There is a development of the granulation tissue or fibrosis in and around that area that we are having. So this is something which is we are anatomically speculating. There is another pattern which is the functional. Functional in the sense it will dynamicity, it will tell that yes, the vascularity has in the tumor has gone down. So even though it is not reducing the size, the functional aspect actually has gone down. And the cellularity, suppose it is a neving and it is having highly cellular pattern and the diffusion, it is gone down in its parameters. So these are certain things. Actually, if the anatomically access, it is good. If there is anatomy is constant, then you have to see the functional aspect. And that's what we are doing sometimes into the metabolic imaging. If it remains stable and things like that, sometimes we say that yes, that QV has gone down from this to this value, and probably it will indicate that the tumor is responding, even though it is not shrinking in the size. So there are some things like multiple parameters that are actually there, and we can see that the first one it is having cells and the second one is having another cell. So it is, looks like it is going to the similar one. But what we see here is that the ADC component is going down. We see that it is becoming more bright as compared to the tumor, even though it is slightly increased in the size. And the ADC component are going to reduce. This is actually most treatment changes. This is actually viability. So even though it looks like it is not responding on the morphological sequences, it will help in assessing the ADCs, the functional and other aspects in which it will try to tell yes, it is responding to this. So sometimes we will say, yeah, yes, this thing. So they don't want to amputate something. They do an amputation and it turned out to be okay. It is only tumor necrosis. So this is one thing that they want to do. But MR is good in assessing both pre and post assessment in a very good way. But we are seeing a lot of response in other conditions also. Like if you see in this particular patient, what we are actually interested, the planes with this thing, the size of the tumor, uh, and what we are seeing on the post chemotherapy assessment, that there is a significant shrinkage in the pelvis. So in this particular case, we don't require to do anything else. We will see yes, it is responding well to the tumor, and that's the graph actually we are seeing. If it is showing rapid uptake and rapid fall, then it is still having a lot of neoantigenesis. But if it is having plateauing, then we will see yes, most of these actually has undergone necrosis. We probably try to estimate whether it is more than 90 or 95, like the histopathology will do, but that will require a lot of time. And so you have to go through the entire tumor set. You have to see the area which are having hypervascularity, and then you put ROI into these regions, and these ROIs will tell you the graph pattern. So you have to put at least 10, 15 ROIs. Nobody is having that kind of time, and that's why we are not doing that kind of assessment. But yes, if it is shrinking significantly and it is not changing the management, then yes. If it is like there is a dicey management issues, then we will go through the tumor again. We will put the ROIs and we will tell yes, there's a responded. Again, you can see that uh, the first tumor in which there is a lot of soft tissue actually. I don't know the quality of. So you can see that there is a lot of soft tissue. What we are actually seeing on the response is that the bone is actually forming. The bone formation that is coming is actually a response. The tumor, if you see the girth, shoulder girth that is coming in this region, the arm diameter, it is actually shrinking, it's becoming more symmetrical. The soft tissue is going down, the bone formation is starting, the cortex is not well delineated earlier, and now you can see that there is a well delineation. Post chemotherapy has been undergone surgery, and this how it looks, because these tumors can have a lot of mobility issues later on, and we have to advise that. So you can see that the planes here, and now this area which we are actually seeing the darker areas, let's say, a fibrous tissue. There is a lot of shrinkage in the solid areas of the tumor. Now it is becoming relatively tissue bright. It will indicate that there is a lot of necrosis happening. And if we give contrast, we get not enhanced. And that will indicate that we are dealing with necrosis in that as well. Again, we will see that the distal end. What we are seeing is that if it is an osteoid forming tumor, you will have a dense florid reaction that is coming up, and that will indicate that it is responding. There was a soft tissue. When actually you give chemo, this soft tissue will mineralize and it will give rise to dense solid reaction. Again, we find mineralize and give dense solid reaction. Somebody who is visiting directly these radiographs might give these as a benign lesion because there is a dense solid reaction. One needs to correlate that there was previous something else, now it is something else. We have seen the wrong reports in that sense. And if you see that there is a formation of the cortex now, it is better appreciated. The soft tissue that is seen in the periosseous region, it is shrinking inside. And that will indicate that yes, we are taking the response, and then these can undergo resection because it is involving the physis. They have to go the total knee replacement. In those aspects, it is into the diaphysis with only the implant that something exists. So there is a lot of depend upon the location of the tumor. Even though it is 4 or 5 centimeter size, but the location is such that it has to undergo a knee replacement. If it's similarly in the diaphysis, it might be something different. So there are many aspects that is required to deal with these tumors. But we see here that again it is responding well, tumor is responding well, but the patient was not having that kind of money, and that's why it has been undergone the nail cement reconstruction and protection plasty and other issues that are coming up. So it is very well responding, but due to money issues also, sometimes these patients cannot undergo the implant. So we are actually trying to provide them as far as possible. Again, assessing response, you might come across that sometimes there could be GCTs and EPCs and other issues. Always the response in any sort of these tumors is that solidification of the bone, remodeling of the bone is coming into the normal shape, and that will indicate the response. So if we have a lytic lesion here, and at the post-embolization, you can see that forming the cortex well will indicate that yes, the treatment is effective, it is responding well to the treatment, and that's what we want to do. But what happened actually in this particular patient, there was a response one time, but there is no response subsequent times. And what we see is here that it is ballooning like anything, and that's why it has been resected, because it is not responding to the sclerosing therapy, and that's why we have to resect it, and we have to follow these patients through the radiograph, whether it is any development of any local recurrence signs, and the local recurrence signs is usually the same that is seen in the index can indicate the lysis of the lesion. So this is something which is the patient, it has been diagnosed in GCT, and there is a path fracture that has happened, and the patient is put on denosumab. And post denosumab, what we see here, you can see that the classical platelets is ketoacidosis that are there. We will see that the bone is relatively well formed. We don't see the cortex here, but now the cortex is actually starting, and you can delineate the cortex. It was not visible here. It is shrinking, it is solidifying, and the thing. But what happens actually? It is actually having a path fracture, having distortion of the joint, involvement of the joint, and that is the reason it is actually going to major knee replacement. Otherwise, these could be just curated. So GCTs can be curated left and right, but again, the location is extremely important. The concept of immobilization in these tumors while on the treatment is extremely crucial. Because once they develop the fracture, there is a very less chance that they will undergo resection sparing surgery. They have to undergo resection, and the resections are going to be morbid and big in that terms. So this is something like if we come across the giant cell tumors of the pelvis and other issues, surgeries are not feasible here, and that's why these are typically controlled with serial embolization. And through these serial embolizations, they will respond. We have done to serial embolization. What we have seen that it is after certain cycles, actually again, it was coming back because the patient has defaulted. What is the amount of uh, thing he has to pay when they default on the treatment? If such a small tumor actually is becoming so big and irregular compared to the symptoms and other things. And that time it is very difficult to salvage these tumors because this is the location where surgery is not feasible. Probably then it is a combination of RT plus other things. Um, so what basically we do that once we so what we are talking about the contrast. So this is you can see this is the contrast. So the gadolinium is entirely pulling, it is staying in the tumor. You know what happens, you can see that the dye when we have given it pulling into the uh, tumor in the angioembolization. Post angioembolization, when actually we completely obliterate these vessels, what you are seeing in the tumor is the necrosis. You can see that it's not an empty. So this area has entirely gone with the drug that he has given, the embolizing materials that he has given. And that is something we actually desirable. And that is something you also desire, that these tumor and significant necrosis um, in these aspects. So that we have discussed that here. Any other, anything else? I think they are also. What is anything they are non-metastatic right document area or just that with pathological fracture. And once they are with a pathological fracture, you can see that why we have gone for certain rotation plastic procedure in this patient is that it is going into the knee joint. You can see that this is a patellar tendon that is there, or back pad is there, and this is the articular margin, and it is going and obstructing all involved in the joint. Even though it shrinks significantly, we have to go and revise the margins that are actually in the previous scan. So we have to actually take out that knee joint, and then we have to use the tibia and the femur together if the patient is not having the money to pay for the implant. And that is actually happened in this particular patient. Leavings are usually tumors because there is a very, very large professional component as or they still don't have that kind of component. But see, here is the cortex. How far the tissue has traveled, that will indicate that this is more likely to be this thing. And if you see on the X-ray, there is no matrix. So round cell tumors don't produce any matrix. That's how we will try to identify that there is no matrix producing tumor. So only two, with lymphoma and living sarcoma, they will not come with any kind of matrix. And they are difficult to identify because they grow so rapidly that sometimes you only don't see any cortex destruction. They will just permeate through the nervous canal, produce a tissue. And that's why platforms where the chances of healing are very high, most of them are actually missed on the X-rays. That's why the role of MRI when the patients are symptomatic is extremely, extremely crucial to actually rule out whether it is anything significant in the pelvis. Any questions? Some are actually sleeping, I can see. But sorry, it is good weather and I'm taking lecture here. It is not fine. Yeah, so yeah, so that it is good that what we are doing in the uh, MRI is the loco-regional staging. So we are doing the staging of the tumor or and that bone. We are including the proximal distal joint because we have to include the entire bone into that. If it is arising from the humerus, we have to include the entire humerus. Skip lesions are more likely to occur in uh, the same bone, more likely. Okay? But there could be skips between the other bones. You, either you could do a whole body staging system, you can do with the bone scan, you can do with the whole body MRI, and you can do with the fluoride FAT. So all these are feasible. The cheapest and the finest is the bone scan. Okay? So that will tell you there are multi-centric lesions. It will not tell you the further details. If you are having doubt, then you can actually prove with the PET-CT or MRI. But if it is multifocal, it is into many different bones, then from our side, it is declared as a best supportive care. So if it is having more than two bone mats, having lung mat, then we upfront we will declare that it is going to be bone best supportive care. We will don't pursue further. Uh, so it is a different bone. Yes, yes. It is in a different bone, but it is considered a skip mat because most of the time what happens if the lesion is in the uh, lower side of the femur, there are many blood vessels that are actually uh, continuous. They have the same supply because once there is a new angiogenesis, you will recruit many blood vessels and probably some of the tributaries that will go into that area. So we will consider that a mistake, but you can call them metastatic also, depending upon the kind of treatment there. So if they are coming under one surgery, we will consider that as escape. If they are not coming in the same surgery, then they are going to be metastatic. So as far as we can salvage them with some kinds of surgical intervention, they are going to be escape. But if we cannot salvage them, suppose if there is a tumor that is there into the femur and the met coming into the vertebra, we cannot salvage. We need either the supplement of the RT. If the RT people say yes, we can do some kind of radiation in that. It is single solitary lung mat or a single solitary bone mat. Okay, then we will still can go ahead with the curative intent. But if they say no, if we cannot do it, then again from our side it's going to be best support because we cannot reset vertebra. So that is the one thing that is there. And we have seen skips, uh, very unusual location. We have seen skips in skull also. So skull bone also. So that's why one whole body imaging is really must. And the bone scan is because the chances that it will go to bone as compared to the lung is very high. So sarcomas are usually going either into the bones or either into the lung. So that's why we will do bone scan plus NCCT thorax. NCCT thorax to look for lung mets and bone scan just to look for distal region for distal metastasis, bone lesion. They don't go into the viscera, and that's why there is an argument whether there is a bone scan is needed or a PET scan is needed. Because once you do PET scan, it will have an anatomical imaging also. But in these particular patients, we don't require that because they are unlikely to go into the liver, kidney, other issues, so pancreas. So they are either lung or either bone. So bone scan plus sensitivity to is as good as doing a PET scan or a whole body MRI. Nowadays, whole body MRI people are doing the best because it doesn't require any intravenous cannulation. It doesn't require any injection of the radiopharmaceutical. The time required is actually less. There is no holding period, holding time, hot bed. Other issues are actually not there. So it is just an half an hour sequence. Earlier, the timing of the sequences are much more. Now only four sequences that will give you the equal amount of this thing. Now actually they are also giving the MIF images, the kind of images that are given the PET scan. So actually whole body MRI, especially in the UK and the other European countries, it is replacing the things. The competition there is not that much. Here is the branch competition that is existing in here. Actually, the nuclear medicine comes under part of radiology. So they will weigh the merit of doing which sequence is better because they are actually nice guidance actually also involve the financial aspects and the country resources aspect. But our is a different scenario. Anything else? I think it's too toxic.